Slap tear is superior labral anteroposterior tear. Classification is Sender classification. It normally has 10 types, but first 4 are important. Type 1 is degenerative fraying of bicep and labrum. This needs debridement. Type 2 is detached labrum and bicep tendon anchor. Type 3 is bucket handle tear of labrum with intact anchor. And type 4 is bucket handle tear of labrum and detached anchor. This is the highest incidence of labral tear happens at the bicep tendon because it has a poor blood supply and blood supply to the labrum from the capsule. This can happen with repetitive overhead activities. Most common pattern is bicep tendon attachment at the superior labrum at 12 o'clock position. There are some anatomical variations when doing a scopy. One is sublabral foramen recess. This can happen in 12% of the population. Second is Beaufort complex. This has cord-like MGHL and absent anterosuperior labrum. The incidence of this is 1.5%. If you attach the absent anterosuperior labrum in Beaufort complex, it will reduce the range of motion and elevation. Investigations are clinical findings. You can do the clinical findings will help you identify the type of the slap lesion. The test for this is called O'Brien test. Arm is adducted 20 degrees and forward flexion to 90 degrees, thumb down, and try to resist elevation of the arm. It is positive when the patient feels pain at the level of superior labrum region. The pain will relieve when thumb points upward, because at that position bicep becomes more active and this reduces the pain. MRI will show paralabral ganglion cyst in a spinal glenoid notch. This is associated with slap tears. Surgery is controversial, typically in overhead athletes, because repair is not consistent. You can either repair or do a tenotomy. Post-operatively focus on healing and reestablish motion, followed by strengthening exercises.